Okay, now I do. Said she was speaking and I couldn't hear her. I don't hear her.
Thank you for joining today's Nile webinar. This is Lisa, the Education Manager with Immunize Nevada, and I will be today's moderator. Before we get started, I'd like to review a couple of housekeeping items. First, locate the chat box in the bottom left corner of your screen. If you have any questions, type them into the chat box and we will address those questions at the end of the presentation. Secondly, if you have requested nursing or pharmacy and continuing education credits for today's webinar, please make sure you complete the survey in the post-webinar email. The email will be sent out by the end of the day today, and all CEUs will be emailed out within the next week. A little disclaimer, Immunize Nevada's Nile webinars are made possible by the generosity of speakers who donate their time and expertise to the benefit of the coalition. The expectation and goal is for community partners to gain knowledge on immunization-related topics through a non-branded, unbiased presentation. I'd like to now turn it over to our speaker, Joellen Wolicki, who is a nurse educator with the Centers for Disease Control and Prevention. She served for 14 years as a nurse consultant with the Michigan Department of Community Health Division of Immunization, and since then, she has been with the CDC for 7 years. She travels throughout the United States to educate healthcare providers on immunization, and Joellen holds a Bachelor of Science degree in nursing from the University of Detroit Mercy. So we're so happy to have you today, Joellen, and I'll let you take it from here.
Thank you, and thanks everyone who's listening for taking time out of your busy clinic day for participating on this webinar. So we're going to talk about the adult. We're going to lead off with adult immunization and standards for adult immunization practice. First thing I have to do is let you know that I am a federal government employee with no financial interest in or conflict with the manufacturer of any product named in this presentation. I am not going to discuss the off-label use of any vaccine, and I will not be talking about vaccines that are not currently licensed by the Food and Drug Administration or FDA. So a quick overview of what we're going to be talking about for the next hour is the disease burden among adults when we're talking about vaccine preventable diseases. We're going to talk about the standards for adult immunization practices and what should be going on. I am going to touch on the recommended immunization schedule for adults and highlight some of the changes for this year's schedule versus last year's schedule. And then, of course, we're going to talk about strategies to improve vaccination coverage, which essentially means at the clinic level that your patients are going to be protected from vaccine preventable diseases, which is a goal for all of us. So let's start off with adults and vaccine preventable diseases. So let's start by discussing in pneumococcal hepatitis B disease and human papillomavirus disease. Oftentimes, people think that only children are vulnerable for vaccine preventable diseases, and they are the only ones that need vaccines. When I was working in a clinic, I would often hear parents say to their kids, you know, you'll get all your shots as a kid and then you don't need any when you get older. And that's not true at all. And you can see on this slide that adults are vulnerable too and need protection. So pneumococcal disease is an illness caused by a bacteria. When pneumococcal bacteria spreads from the nose and throats to the ears or sinuses, it generally causes a mild infection, but it can also spread to other parts of the body, which can lead to severe health problems, such as infections in the lungs, which is pneumonia. And you can see on this slide about 900,000 adults get pneumococcal pneumonia every year, which lead to as many as 400,000 hospitalizations and 19,000 deaths. It can also go into the bloodstream, which is known as bacteremia, and the lining of the brain and the spinal cord, which is meningitis. In some cases, pneumococcal disease can be life-threatening, as we see in this bullet that it causes 19,000 deaths. Or it can cause long-term problems like brain damage, hearing loss, or loss of arms or legs. Age and certain chronic health conditions can increase the risk of invasive disease, can put people at an increased risk. When we're talking about hepatitis B, 700,000 to 1.4 million people suffer from chronic hepatitis B with complications such as liver cancer. Hepatitis B causes flu-like illness with a loss of appetite, nausea, vomiting, rashes, joint pain, and jaundice. The virus stays in the liver for some people for the rest of their lives and can result in severe liver disease, including fatal cancers. Adults who are at risk for hepatitis B infection include healthcare workers, adults who have chronic health conditions like diabetes, renal disease, chronic liver disease, or HIV infection. And moving on to human papillomavirus disease, HPV causes over 27,000 cancers in men and women each year in this country. About 4,000 women die each year in this country from cervical cancer. So let's take a little bit to look a little bit closer at HPV because it's a vaccine that is compared to some of them a little bit of a newer vaccine. HPV is a common virus. Clinical manifestations of HPV infection include anogenital warts, recurrent respiratory papillomatosis, cervical cancer precursors, and cancers of the cervix, anus, vagina, vulva, penile, and oropharyngeal cancers. Most people never know that they've been infected. Women may find out that they're infected because of an abnormal Pap test or a positive HPV test or a diagnosis of genital warts. Men may find out because of a genital wart diagnosis as well. So pertussis, or whooping cough, is a highly contagious respiratory tract infection caused by a bacteria. Since the 1980s, we've seen an increase in the number of reported cases of pertussis. Babies too young to get vaccinated are most at risk for serious illness, but adults can contract the disease too and become fairly seriously ill. It can cause prolonged cold symptoms, lead to spells of violent coughing or choking, make it hard to breathe, eat, or drink. Some people have even reported rib fractures from the severe coughing. Babies often get the disease from a parent, a caregiver, or a relative. Shingles, or zoster, is a painful rash that develops on one side of the body, often the face or torso. The rash consists of blisters that typically scab over in 7 to 10 days and clears up to within 2 to 4 weeks. What people often talk about and what is most debilitating about this disease is the pain. It usually is an intense burning sensation along the rash. This pain can last after the rash disappears and is called postherpetic neuralgia, and it is the most common complication of shingles. The risk of getting shingles and postherpetic neuralgia increases as people get older. There are about 1 million cases of zoster annually in the U.S., with 10 to 11 cases per 1,000 per year in persons 60 years of age and older. And influenza, we're in flu season right now, is a very contagious viral infection of the nose, throat, and lungs. We hear a lot about influenza right now because we are having a fairly severe season. Older adults and those with certain health conditions or medical conditions are at higher risk for serious complications, even death. But we do know that children can die from influenza also. An influenza virus causes a sudden high fever, chills, a dry cough, headache, runny nose, sore throat, muscle and joint pain, and extreme fatigue that can last from several days to weeks. Influenza may lead to hospitalization or even death. The disease burden varies from year to year, but averages millions of cases, 226,000 hospitalizations, and more than 75 cases are amongst adults. There are 3,000 to 56,000 deaths annually, and more than 90% of those are among adults. So looking at the 2015-2016 influenza season, CDC estimates that influenza vaccination prevented approximately 5.1 million influenza illnesses, 2.5 million influenza-associated medical visits, and 71,000 influenza-associated hospitalizations. So we can see what's demonstrated on this slide is that vaccines do work, and they do, while they may not always totally prevent illness, they are going to prevent the severe complications, hospitalizations, and maybe even medical visits. This slide continues to outline the benefits of flu vaccination. While it may not prevent all the flu cases, as I just mentioned, you can see that there's a 78% reduction in deaths attributable to any cause and an 87% reduction in hospitalizations attributable to an acute respiratory or cardiovascular disease. Persons with diabetes also gain benefits from vaccination with reductions in complications and hospitalizations. So there have been a couple of studies, and we know that an acute respiratory illness or an influenza-like illness increases the risk of an acute MI, and it increases the risk by 2 times. But you can see here on this slide, based on these 2 studies, that influenza vaccine decreased cardiac events and was effective in preventing an MI in persons with existing cardiovascular disease, and was also effective in preventing other major cardiac events. Influenza vaccination is recommended by the American College of Cardiology and the American Heart Association. It is on par or better than accepted preventative measures such as taking statins, antihypertensive medication, and smoking cessation. And then while I just spent a fair amount of time talking about the complications and influenza illness on a wide scale, it is important to remember that I don't want to lose sight of the fact that flu can be a serious risk to those that we may not consider vulnerable, and that would be healthy young adults. And on this slide, it highlights Jacob Ryan Schmidt, a healthy 27-year-old who ultimately died from influenza. His story, along with others that had influenza, can be found on the National Foundation for Infectious Diseases website. Another source for stories on families affected by influenza is the Families Fighting Flu website. So now I'd like to take some time to talk about the recommended immunization schedule for adults aged 19 years and older. So here's the front or the cover of this year's schedule. Note the schedule year is up in the right-hand corner. The immunization schedule is updated annually, with the 2018 schedule was just published earlier this month. So if you have copies posted in your office, please check and make sure that you have the current year's schedule, and if they're the last year's schedule, take them out, recycle them, and replace them with the current schedule for staff. There are 2 figures in the adult schedule, and this is Figure 1. Figure 1 outlines the routine recommendations based on age. Yellow bars mean the vaccine is routinely recommended for persons in that age group. Purple bars indicate the vaccine is recommended for those adults with a high-risk condition. Figure 2 outlines vaccination recommendations based on medical conditions or other indications. Yellow and purple bars on this figure still mean the same thing, so they mean routinely recommended or for those at risk. And you'll see on this slide red, which is a new color for this graph, and it means that the vaccine is contraindicated in those populations. So when we look at immunization schedules, we normally look at them and think, well, the vaccines are down the side, which is the case for this figure, but usually we're used to seeing ages across the top. But in Figure 2, the ages aren't across the top. It is the medical conditions or other indications. So you can see pregnancies highlighted, immunocompromised persons, persons with asplenia, end-stage renal disease, heart disease, diabetes. They're across. Those are indications that are across the top that would indicate the need for certain vaccines. And then we have what I call the most important part of this section. I know everyone likes the figures. They're clean. They're simpler. But really, truly, the nitty-gritty information that you need when you're immunizing somebody is in the footnotes. And good news about the footnotes is there was an effort made over the past year to make them simpler and plainer, and I think this year you'll be pleased to find that they are much easier to read and understand. And then last but not least in the 2018 schedule is a table of contraindications and precautions for vaccines when administering them to adults age 19 years of age and older. We all know that before administering vaccines, we screen them for potential contraindications and precautions, and here's the table that you can use to help you determine if the condition that's noted on the screening tool is actually a true contraindication and can the person be vaccinated or not. So while I know that for many of you, you print off copies of schedules for staff to use when assessing patients, I'd like to take a moment to highlight two other ways to make the schedule accessible for your staff. Syndication allows the CDC schedule to be seen on your website. This method ensures that the schedules on your site will always be the most current. You're actually displaying what is on the CDC schedule from the CDC website on your page, and it will automatically, it will not change anything else on your page. It won't make anything else look different, but you're actually displaying the schedule from our page. So nothing else changes on your web page. One of the benefits of this is that if we change something on the schedule, it's seamless. It's changed on your website also. The other method that I would like to highlight are the CDC Vaccine Schedule apps. So these are for healthcare. These allow healthcare personnel immediate access to the most up-to-date immunization schedule. Healthcare personnel can view the full adult schedule, including medical conditions, footnotes on smartphones and tablet devices. These are free downloads available from the iTunes App Store or from the Google Play App Store. The 2018 version of the Schedule app will not be available until March. So until then, if you're one of the persons who wants to try the app or have already been using the app, then you're going to need to use the online or the printable versions. So now let's go through some of the changes that were made to this year's schedule versus last year's schedule. So as I mentioned earlier, a lot of the changes happened in the formatting of the text for either the figures or the footnotes. So Tdap/TD was replaced with Tdap or TD in the figures or in figures 1 and 2, and the text in the indication bar has been revised to 1 dose of Tdap and then a TD booster every 10 years. Again, the recommendations for Tdap and TD have not changed. We're just trying to make the information easier for you, clearer and easier to understand. With HPV in Figure 1, the text in the bar has been revised to indicate 2 or 3 doses depending on the age that the series was started. And this is because we know now for HPV we have 2 schedules. We have a 2-dose schedule and a 3-dose schedule, and we just want the information to reflect that. Detailed information about the schedule is included in the footnotes. MMR. We had some updates to MMR, and one of the recommendations that was updated and published last year was to administer 1 dose of MMR to persons who previously received 2 or more doses of MUPS-containing vaccine and are identified by public health authority to be at increased risk during a mumps outbreak. And that text in the indication bar has been changed to indicate that 1 or 2 doses depending on whether for indications based on ACIP recommendations. Then we have men ACWY vaccine or meningococcal conjugate vaccine. The brand names for this are Menactra and Menveo. And figures 1 and 2, the indication bar has been revised to show the schedule as 1 or 2 doses depending on indication, and then a booster every 5 years if the risk remains. So that has been updated, as has the footnotes. We have removed meningococcal polysaccharide vaccine from the schedule as it is no longer available. With zoster is the vaccine that we probably have seen the most changes over the last year, and we have a new vaccine. So with zoster, we have Zostavax vaccine, and we have Shingrix vaccine now. Recommendations have been updated to ACIP now recommends administer 2 doses of recombinant zoster vaccine, which is abbreviated RZV, which is Shingrix, 2 to 6 months apart to adults 50 years of age or older, regardless of past episodes of shingles or if they were previously vaccinated with zoster vaccine, Zostavax. We administer 2 doses of Shingrix 2 to 6 months apart to adults who previously received zoster vaccine. We need to make sure, if you've been in immunizations for any time, you know that we immunization nurses, we live by our intervals. So when we're talking about administering Shingrix to an adult that has previously received Zostavax, we need to separate those doses by at least 2 months. And ACIP did express a preference for Shingrix to be administered over Zostavax. And you'll notice here that we have new abbreviations. So with zoster vaccine, the abbreviation used to be HZV, but now with 2 different vaccines, we need an abbreviation for each. So zoster vaccine is now ZVL, which is zoster vaccine live, and Shingrix vaccine is RZV, which is recombinant zoster vaccine. So let's look a little bit at immunization rates on the next few slides. Knowing immunization rates both nationally and for facilities is very important. We can only improve what we measure. So as you know, there are 2 types of pneumococcal vaccine, and this table here shows them both. And our goal and our 2020 goals associated with each vaccine. You can see for the years 2013, 14, and 15, we did make a little bit of stride in 15 to get more people vaccinated, both in the groups 19 through 64 and with persons 65 years of age and older, but we're certainly nowhere near our targeted goals, which you can see by the little targets on the graph. And with zoster vaccine, with 2013, 14, 15, we were able to reach the goal of 30%. Hepatitis A, this slide shows coverage estimates for hepatitis A vaccination among adults based on National Health Interview Survey results. Hepatitis A is not routinely recommended for unvaccinated adults. This vaccine is recommended based on risk factors. And you can see on this slide you can see those with chronic liver disease is certainly a risk factor for hepatitis B, and we're nowhere near what we need to have vaccinated. All right. Another risk factor is travel. And these are where the highest vaccination rates are seen, is when travelers are going to areas where the disease is endemic. I often tell people that maybe that might be something you want to ask about when you screen people for vaccinations. Do you plan any international travel soon? Because we all know that oftentimes patients do not come to us in time to get all the doses they need in a series. Sometimes I think it seems like they're coming to us on the way to the airport to catch the plane. So looking at Tdap, here are the vaccination rates from Tdap that were based on the 2015 National Health Interview Survey. And you can see here that the biggest vaccination rates, or the highest vaccination rates, are among healthcare personnel, although the rates for persons that are non-healthcare personnel are not too far behind. And with HPV vaccination coverage, we're looking here at this chart. You can see the female rates are in the solid bars, and male rates are in the hash mark bars, or the non-solid bars. And we're looking at least 1 dose ever for females and males 19 through 26 years of age. And we certainly know that they need more than 1 dose to be protected, and that we're not where we want to be with this. So HPV vaccination should be something that everybody is looking at. And then when we look at coverage among older adults based on race and ethnicity, we can see that disparities continue to be an issue. When we're looking at adults 65 years of age and older, Caucasian persons are much more likely to be vaccinated with routinely recommended vaccines than African, Asian, or Hispanic American populations. The only exception is influenza vaccine, where you can see that Asian Americans have the highest vaccination rate. So with that base of knowledge with the schedule and with rates and with information about the disease, now's the time to actually build upon that, and let's talk about the standards for adult immunization practice. The standards for adult immunization practice were originally developed in 1990 to improve vaccination or vaccine delivery to adults. They were updated in 2014 by the National Vaccine Advisory Committee, often abbreviated as NVAC. NVAC created these standards and updated the standards as a call to all healthcare professionals, whether they provide vaccinations or not, to take steps to ensure that their adult patients are fully immunized. These immunization practices are considered standard of care. They include assessing for needed vaccines at every clinical encounter, strongly recommended needed vaccines, administering the vaccines then or referring patients out for the service, and if the vaccines were administering them, documenting them accurately. And let's take a few minutes to review each one. So assessing for needed vaccines is the first activity that healthcare providers should perform to ensure that their patients are protected. This should be done at every clinical encounter because people change from one visit to the next. Patients age, they develop medical conditions that may require specific vaccines. There are lifestyle changes that can occur. Perhaps there's a new baby in the home. Maybe a career change, say into the healthcare profession, which we all know has specific immunization recommendations just for it, because healthcare personnel are at high or increased risk of exposure to vaccine-preventable disease by the nature of the work that they do. And then there's travel. Studies consistently show that a strong recommendation from the provider is the single best predictor of vaccination for any vaccine. You, as their healthcare provider, are their most trusted source of information. So that then begs the question is, what is an effective recommendation? What do we mean by making a strong, effective recommendation? And a strong, the best and most effective recommendation for vaccination is when all needed vaccines are recommended in the same way on the same day. You often will hear about this as a bundled recommendation. So it should be clear, it should be simple, there should be no question that you are advocating for them to be vaccinated. So I put an example here about today you need 2 vaccines, flu and pneumococcal vaccines. These vaccines will protect you from influenza and invasive pneumococcal disease. We'll give you those shots today. You're telling them they need the vaccines, and you're telling them they can get them today, not on another day. That's what you recommend. After recommending the vaccines, the next is administering the vaccines if you have them in your office. Research shows that when patients receive a vaccine recommendation and are offered the vaccine at the same time, they are much more likely to be vaccinated. When referring patients out for vaccines, it's very important not just to tell them these are the vaccines you need and leave it at that. What you want to do is tell them where they can go in your area to get those vaccines. Offer them options of places they can go, such as their local health department or maybe a local pharmacy. Make it easier for them to get vaccinated. And then when they return for a subsequent clinical visit, ask them if they were vaccinated. This slide shows data from the CDC Internet Survey that was conducted in 2017. What it demonstrates is patients are most often vaccinated, like I said earlier, if the vaccine is offered and recommended. And you can see here why we make that statement. This information drives home the importance of your recommendation to patients, but also drives home the importance of offering the vaccines. Another point that I like to make whenever I talk about this is the importance of keeping all staff on the same page. So while it's important to recommend and it's important to offer the vaccine, it's also important to align consistent immunization messages for all staff. You want to communicate with the mission that vaccines are important, vaccines keep people healthy. And so all staff need to be saying the same thing. You certainly do not want to have a discussion with a patient about getting influenza vaccine, and then they decide to be vaccinated only to have the person who goes in to administer the vaccine tell them that they never get flu vaccine, it gives them the flu. So create or share talking points among staff. Let everybody know that we want to give the same recommendation when we're talking about vaccines. So you need to educate staff about vaccine recommendations, including schedule, administration, storage, and handling. And you certainly want to share those talking points or those messages with all staff, including staff at the front desk. Immunization records are extremely important for many reasons. Often people need to show proof of vaccination for certain careers or travel, but most importantly, when assessing for needed vaccines for the future, you will need an accurate, up-to-date history. So you want to record vaccinations in the patient's medical record, provide documentation of vaccines received to patients for their personal record. You want to educate them about this, especially if you're referring people out, because you want them to bring you back the information that they received the vaccines. And then if you are an immunization provider and your immunization information system accepts adult information, I highly, highly encourage you to put the vaccination records into the state IIS. So when we're talking about federal law requires the following information be documented on the patient's paper or electronic medical record or in a permanent office log, and that would be the vaccine manufacturer, the vaccine lot number, the date the vaccine is administered, the name, office, and title of the healthcare provider administering the vaccine, the vaccine information statement edition date, which is located on the lower right-hand corner on the back of the VIS, and the date the VIS was given to the patient, the parent, or the guardian. Some states or local jurisdictions may have additional requirements, so you may want to contact your immunization program at your state or local health department for any additional guidance you may need. So let's talk about evidence-based strategies to improve vaccination rates. The Guide to the Community Preventative Services identifies a number of best practices related to immunizations, including reduced missed opportunities, integrating standing orders, using a reminder, prompts to providers, educating clinicians and staff, and then using a patient reminder recall system and using immunization information systems. The best strategy is to use a combination of these strategies. So a missed opportunity is when a healthcare encounter in which a person is eligible to receive a vaccine but is not vaccinated completely. Reasons for missed opportunities are lack of simultaneous administration, they're unaware that the patient needed additional vaccines, invalid contraindications, they thought there was a reason why they couldn't be vaccinated, but yet that wasn't the case. Reimbursement problems or inappropriate clinic policies. When we're talking about standing orders, they are one of the most proven effective strategies to improve immunization rates within a facility. Standing orders authorize nurses and pharmacists and other appropriately trained healthcare personnel, where allowed by state law, to assess and administer the vaccine according to protocol approved by a physician. They don't need to actually see someone. They can just come in and have what is often referred to as a vaccine-only visit. So this leads us to the slide that knowledgeable staff are key when you're talking about administering, creating an immunization program. So before administering vaccines, everyone should be knowledgeable about the vaccines. They should have received competency-based training. The best way to do this is to integrate it into policies such as and procedures such as new staff orientation and annual education requirements, and then ongoing education whenever a vaccine is added to your inventory or recommendations are updated. CDC has a number of resources available for staff. We have self-study modules. We have net conferences. The next one is on March 21st, 2018. You can sign up for and hear in detail the changes for the adult and the child immunization schedule, and we also have webcasts and online self-study. Continuing education is available for all of our programs and materials, and that is for a wide range of healthcare professionals, including physicians, nurses, pharmacists, and others. Patient reminder recall. It's important. A reminder is to let them know that an immunization is due. Recall is to let them know that immunizations are past due. This can be done in a variety of ways, and it has shown to be very effective. It could be an auto dialer. It could be an email sent. It could be something sent in the mail, a reminder notice sent in the mail. But immunization schedules are complicated, and expecting parents to remember when a vaccine is due is often a way that they're going to miss a dose. So it's best if we remind them when one is due. The difference between a patient reminder and a provider reminder, or what is sometimes referred to as provider prompts, is that sometimes these are available within electronic health records, and they will pop up and they will say, you know what, influenza vaccine is due today, or they're missing this, or they're missing that. So these two can be done in a variety of ways, like computer-generated lists, stamped note on a chart, maybe clip an immunization due note to the chart, something like that. So there's a wide variety of ways to do this, but these have also been shown as effective that you're not going to miss an opportunity during that clinical encounter. Documenting vaccines in an IIS can benefit your practice by consolidating records, help you assess the immunization status and what is needed. So most IIS is not only a repository for an immunization history, but it will also forecast out what that patient needs based on the history that's in the IIS. So you're going to want to make sure that if you know about a vaccine dose, it's in the IIS so it can assess correctly. Remember, it's very important to have that accurate history to access correctly. You can also, some IIS will also help your office look at immunization coverage rates, and some will also facilitate the use of reminder recall notifications for patients. And you can see here, this slide demonstrates the percent of healthcare practices that reported implementing the standards by different components, and you can see that the majority are reporting that assessing, recommending, and administering or referring patients out to other providers. Fewer report using an IIS as seen in the red bar here. And this information is divided out based on type of healthcare provider or facility it is, family medicine versus internal medicine versus other specialties or a pharmacy. Reducing other barriers to immunization. There are other obstacles that may exist in practice settings that are unknown to a provider. Barriers may be physiological or psychological. Physical barriers can be waiting time and distance, inconvenient hours. Maybe there's not any hours that are after work for patients who need to work during the day. Psychological barriers to immunization are often more subtle, but they may be just as important. Unpleasant experiences, including fear of immunizations or being criticized previously for a missed appointment, may lead clients to postpone receiving needed vaccines. Concerns about patient safety can also be a problem, so you're certainly going to want to address any safety concerns or help with any things such as needle phobia or something like that. It has been reported by some persons that 30% of the adult population in the U.S. is needle phobic and will avoid a healthcare visit that includes the potential for an injection. So what can be done to improve immunization rates? You increase the convenience and access to vaccines, incorporate vaccination into the patient flow, use IIS to document it, and consider immunization data as a quality measure of choice. And then again, I cannot stress enough the need to provide a strong recommendation to parents or in patients. Here are some, in the last few slides, I'd like to identify some healthcare personnel resources that we have. So with CDC, we have an email service. It's nipinfo@cdc.gov or cdc.gov. cdcinfo@cdc.gov, where you can email questions and we will answer them. We have our immunization website, www.cdc.gov/vaccines. We have a Twitter account. We have an influenza website that you can see, and we have a vaccine safety website that you can see outlined on this slide. We also have, I mentioned earlier, we have apps for the schedule, but we also have a flu app. We also have a MMWR, the Morbidity and Mortality Weekly Report app, and there is a TravelWell app for healthcare personnel. So in summary, I would like to remind you that infections can be prevented through vaccination that impact persons of all age. Adults, especially older adults, are often disproportionately impacted by vaccine preventable diseases. Vaccines are available but underutilized by adults. And ensure that adults are up to date on recommended vaccine, including vaccines they may have not received as a child or an adolescent, is key to helping adults stay healthy and preventing hospitalizations, disabilities, and premature death. And with that, I would like to thank you for your time today and take any questions.
Perfect. Thank you so much, Joellen. Before we say goodbye, we'd like to offer a little bit more time for last-minute questions, so please type those questions into the chat box now. While we are waiting for those questions to be typed in, just a couple of reminders. If you have requested nursing or pharmacy continuing education credits for today's webinar, please make sure you complete the survey in the post-webinar email. The email will only be sent out, the email will be sent out by the end of today, and all CEUs will be emailed out within the next week. If you'd like to view or share this webinar, the recording will be available on our website along with information for future webinars. Please visit immunizenevada.org/webinars for those details. And I will wait for just a second here to see if anyone types. Okay, we do have a question. How would you advocate for HPV vaccine for young boys?
That's a great question. Thank you for that. So what I often share with friends and parents of young boys is that oftentimes adults or parents don't realize that HPV cancers also affect them. So I point out that HPV cancers do affect boys. There's the penile cancers and the anal genital cancers. And then I also talk to them about the fact that HPV vaccine can prevent anal genital warts.
Thank you for that information. The next one here says, just to clarify, Shingrix should be given no less than 2 months after Zostavax?
Yes, that's true.
Okay.
And that information is in the schedule.
Perfect. All right, I will give everyone just a couple more seconds here.
Sometimes I feel like I sleep with my schedule. I don't go anywhere without it. Never leave home without your immunization schedule.
All right, here's another one. Do you have any advice for encouraging adult providers serving the Medicaid population to stock vaccines? This is a challenge as 317 is not an option for that population.
Thank you for that question. And I know it is a challenge because reimbursement can be a challenge amongst Medicaid. When I was at the state level, one of the things that we did is that we partnered with the the Medicare program, and we sent out messages to their providers about the importance of vaccination and about the importance of keeping people healthy, and helped and worked with the Medicare group to talk about different ways to stock vaccines in a fiscally, which would make it more fiscally advantageous to the provider.
Okay. Great. It looks like that's all the questions I have now, unless someone types one in at the last minute here. But that does conclude today's Now webinar. And again, thank you so much, and thank you to those who participated today. And have a great day, everybody.
Thanks. Thanks for listening. Thanks for logging in.
Bye.
Bye.